is Dr. Amy Shu, who is Assistant Director of the Radiation Oncology Service at Memorial Sloan Kettering, and is here to talk to us about radiotherapy for distant disease, another very pertinent area. So thank you for coming and welcome.
Well, thank you very much for the invitation and for this opportunity to talk about using local therapies to manage distant metastatic lesions. I have no financial disclosures. And so in this session, we will review the oligometastatic hypothesis, as well as data that support the local treatment of distant metastatic sites. A lot of this data come from other histologies, but I think it is useful for framing the future directions and what will be helpful in understanding this in breast cancer moving forward. I will also review radiation therapy as an effective modality for treating these metastatic sites. In particular, I'll discuss the technological advances that allow us to do this safely and effectively. And of course, discuss how we can apply our current data and understanding towards the management of metastatic breast cancer patients. So the oligometastatic hypothesis is really a very provocative concept that a subset of stage 4 patients can actually be cured of their disease. It's this thought that in between patients who have, disease localized to their breast and patients who have widely metastatic disease involving all organs, that there exists an intermediate stage where metastatic disease is limited, and that the biology of these tumors and these tumor cells are different and should be managed clinically as a distinct entity. So for the past couple of years, there have been increasing molecular evidence that has supported this concept that limited sites of disease versus polymetastatic disease behaves very differently. So for example, if we do gene expression profiles of metastatic lesions from a patients with a few metastases versus patients with many metastatic lesions, the gene expression profiles of these subsets of patients are very different. And with the availability of and feasibility of doing whole genome sequencing, we now have detailed understanding of how metastatic lesions clonally evolve within patients. And in this very famous paper from 2015, where the authors characterized the evolution of metastatic sites within a patient with prostate cancer, you can see that each metastatic lesion evolves independently. They develop their own mutations, and these individual metastases are capable of even seeding other sites. So taking all these advances in our biologic understanding together, it supports the notion that there could be an intermediate state, an opportunity to intervene with local therapies to alter the biology of metastatic progression in patients. So in the real world, this concept of oligometastatic disease has been validated through multiple prospective randomized trials that have shown clinical benefits to treating these metastatic lesions. So I've highlighted here the current randomized evidence supporting the use of local therapies to these metastatic sites. Most of these studies have been published in just the past few years, and notably, they have been shown in other histologies, for example, lung cancer, prostate cancer, and currently there is only one study that has breast cancer included as part of their inclusion criteria that we can use to apply towards metastatic breast cancer patients. The design of all these studies I've highlighted in this table were randomized, and the types of local management of the metastatic lesions included radiofrequency ablation, but most commonly a form of radiation, specifically ablative or high-dose radiation that is intended to be tumoricidal or treat all the definitively treat all the tumor cells that is targeted. The results from these studies are pretty compelling. In some of these studies, it was actually a benefit in overall survival that was shown to be statistically significant. Other clinically meaningful endpoints include progression-free survival in prostate cancer, freedom from needing androgen deprivation therapy was an endpoint. And I will just briefly talk about the SAMR-COMET trial, which was recently updated in 2020. This was a pan-histology trial, and the most common histology included was breast cancer, comprising 18% of the cohort. So as you can see, in this randomized trial, there was a significant benefit of ablative radiation in prolonging the survival of the patients, including in this trial. Of note, 18% of the patients had breast histology, and most of these patients had limited sites of distant metastases, about 1 to 3. So the data, prospective randomized data for supporting ablation of metastatic lesions in breast cancer are currently limited. There are a lot of retrospective data that support the use of treating metastatic lesions. This is one series that we recently published from Memorial Sloan Kettering. And what we found is that when we used ablative radiation to patients with 5 or fewer metastatic lesions, these patients could achieve long-term disease control. So now that we've reviewed the oligometastatic paradigm and the data in other histologies, I will focus on the use of radiation therapy to manage metastatic sites. I think it's important to keep in mind that radiation therapy has undergone a lot of advances in our ability to target tumors safely and with high anatomic precision. So shown on the left, these are typical treatment fields from how we deliver conventional radiation. This is a technique we most commonly use in the palliative setting when we're simply managing symptoms and we're not looking to achieve long-term local control. As you can see, this method of delivering radiation exposes a lot of normal tissue to radiation therapy. And also, because of the large exposure of the large tissue exposure, we're not able to safely give higher doses of radiation. In contrast with modern techniques, this is an example of a plan using stereotactic body radiosurgery. Through the intersection of these multiple beam angles, we're able to achieve a highly conformal plan that targets the area at risk and really limits any radiation exposure to nearby organs at risk, including, in this example, heart, lungs, and most notably in the spinal cord. We have a few millimeters to spare the toxicities that we would otherwise expect from high-dose radiation to this area. There are a lot of redundant terminology in referring to this. I'll just note here that these terms SBRT or SABR, ablative radiation, or IGRT, they're kind of all referring to the same idea, basically using image guidance to deliver radiation with tighter anatomic margins. This decreases our normal tissue exposure, the toxicity from these treatments, and it enables to deliver much higher doses of radiation that are tumoricidal and that we expect to actually kill all the cells that we are treating. So it's important to understand if this type of ablative radiation is safe to deliver. This is a very recent study that was published by Dr. Shimura. It was a phase 1 study looking at the safety of delivering ablative radiation to multiple metastases. They included patients with breast cancer as well as patients with prostate and non-small cell lung cancer, and up to 4 metastases could be treated using these plans. The intervention delivered was high-dose ablative radiation. They specified very clearly the types of radiation doses that were permitted. Another important understanding from this trial is the safety of delivering it with other systemic therapies. So on this phase 1 trial, they allowed anti-estrogen and HER2-directed therapies to be concurrent with radiation. For cytotoxic agents, it was specified that this would be held during treatment but could be resumed within 2 weeks. So the primary endpoint was grade 3 or higher adverse events within 6 months. And no adverse events were seen within the first 6 months, but as you can see in their curves, there were some grade 3, 4 toxicities that were seen with longer follow-up, especially with treatment in the hilar and pulmonary region, but there were no grade 5 toxicities. So in this final section, we'll discuss how we can apply this to our management of metastatic breast cancer patients. And I think it's important to highlight that oligometastatic disease really encompasses a wide spectrum of disease presentations. I think this is a helpful resource for just characterizing and clarifying the types of disease we're referring to. The European group recently put out these guidelines regarding the characterization and classification of oligometastatic disease. Namely, did the patient have a history of polymetastatic disease? Is a metastatic lesion synchronous or metacranist with a primary presentation? These all, represent different types of biology, and I think it's helpful that we be clear on how we characterize it. So for example, this is, I think, what most of us think of when we think of an oligometastatic breast cancer patient, a primary lesion and maybe one side of distant metastases. These are, I think, most often what's represented in the trials that have been mentioned with de novo presentations of metastatic breast cancer. But there are other ways in which oligometastases can present. For example, a patient could be initially polymetastatic and then have a very remarkable response to systemic therapy, leaving them with only a single site of metastatic progression. And we could consider this to be an induced model of, an induced state of oligometastasis. We also commonly see metacranist presentations, so a patient who had maybe an early stage breast cancer, who has NED for many years, and then develops this isolated site of recurrence distally. And then a model of oligo-progression signifies that this additional site of metastasis developed while on systemic therapy, which could represent maybe a subclone with treatment resistance to the systemic therapy that they are on. So there are several ongoing clinical trials studying, investigating the role of local therapies for metastatic breast cancer, and we're all eagerly awaiting the results. Some of these have recently completed accrual and should report out shortly. But following up the SABR-COMET trial that I had mentioned, that was pan-histology, they are validating those results with larger phase 3 trials, studying it in different numbers of metastatic lesions and seeing if there's a difference. So these are pan-histology studies, breast will be included. In terms of breast-specific studies, NRG-BR002, so that's a follow-up to that phase 1 safety study I showed you, also led by Dr. Shmura, is limited to patients with newly oligometastatic breast cancer and few sites of extracranial disease with an intervention of either SBRT or surgery to treat all the metastatic lesions. And in the next slide, I will review the interim analysis of a phase 2 study that is done at MSK, led by my colleague, Dr. Jillian Tsai. This study is termed CURB, so the use of radiotherapy to block oligo-progression. So I'll note that the inclusion criteria for this study was 5 or fewer progressive lesions. So many of these patients initially were polymetastatic, but it was designed to test the hypothesis that ablative radiation of those metastatic sites that are progressing could prolong progression-free survival. So these were the interim analysis that Dr. Tsai presented at ASTRO just 2 months ago. Again, a randomized intervention of SBRT, and 2 histologies were included, 80 patients on the lung side and 40 patients on the breast side. Within the breast cohort, the the patients included were high-risk metastatic breast patients, either triple-negative or ER-positive disease on chemo, and again, 1 of 5 progressive lesions on systemic therapy. So she presented her interim analysis, and strikingly, the overall result was that SBRT, taking all patients together, did result in a statistically significant improvement of progression-free survival from 11 to 31 weeks. But very interestingly, when she looked at the 2 histologies independently, all of the PFS benefit was driven by the lung cohort. Within the breast cohort, the patients included on this trial, there was actually no difference in the PFS whether or not they got SBRT. I think this trial is really important in establishing and acknowledging histologic differences in diseases when we're thinking about the role of metastatic therapies. I also think it's important to highlight the types of patients that were included. So again, these were high risk, triple negative, ER positive on chemo, all biologic subtypes included together. And many of these patients had multiple lines of prior systemic therapy. There was a median of 2 lines of prior systemic therapy, but some patients had up to 9. And overall, they were poor performers. Whether or not they got SBRT, most of them progressed shortly after enrollment. So I think there still remains a question of if there is a subset of patients who may benefit from SBRT. And going back to the spectrum of oligometastatic disease that I had mentioned, I think a really important stratification that we need to think about for breast cancer are the different biologic subtypes. Obviously, we know that these biologic subtypes have different prognoses, but also the treatment paradigms are so different. We know that the targeted therapies have made huge differences in the survival for ER positive or HER2 positive patients, and the types of treatments that they're on affects the opportunities to treat them, whether it's an induced oligo state or a Metacranist oligo state. So I'll end with a patient vignette of one of these patients with oligo-progression that I think, given all that we know about molecular characterizations of metastases, still begs the opportunity that maybe SBRT could play a role in management of these diseases. So this is a patient that was referred to me by medical oncology. She was 67-year-old and initially presented with polymetastatic disease back in 2009. She did not undergo upfront treatment of her primary disease. She was started on systemic therapy, and her disease was relatively well controlled with a few episodes of isolated progression that prompted switching lines of systemic therapy. There was one small lesion in her supraclav node, actually only palpable in a physical exam, that her medical oncologist biopsied and found that there was indeed disease, so that prompted changing her systemic therapy to fulvestrant and palbo, which she responded to very well. But after a few years on this treatment, that supraclav node started to grow a little bit more, and so he performed a repeat biopsy that showed that there was this mutation in RB1, which is a known mechanism of CDK4/6 resistance. And so he referred this patient for SBRT with the goal of maintaining this patient on the systemic therapy she has been tolerating so well, and also with the thought that maybe we can use SBRT to eradicate the resistant subclones that have escaped the systemic therapy. So that's what I designed. I designed a SBRT plan just targeting this lymph node. She tolerated it very well, and she still she's still doing well and maintained on the same systemic treatment. So in summary, we reviewed some of the emerging data that supports this oligometastatic or potentially curable intermediate metastatic state. We reviewed the role of radiation as an effective form of treating these distant metastases. And also the breast-specific data in clinical trials, it's lacking, and it really emphasizes the importance of studying these patients on trials, and so that we can definitively learn if there's a benefit for SBRT. So it remains to be seen if this benefit that we've seen in other histologies applies to breast cancer patients. I think it's very critical how we select the patients that are enrolled on these trials, and how we can use other technologies such as more sensitive imaging or circulating biomarkers to further define the oligometastatic disease state and which patients may benefit. And it will also be important if we have other ways to monitor patients for treatment efficacy beyond just radiographic disease control. So I want to thank everyone for their attention, and also MSK and the Department of Radiation Oncology for supporting me, of course, all of our patients and their caregivers. So with that, we'll turn it over to the panel.